So now I'm gonna continue, and I might be a little bit out of the sequence of how we're talking about those therapies, because of course we're focusing about all TKIs, but no doubt we're gonna go back to TKIs in a second, but we'll take a pause to talk about another advent in regard to HCC, which is checkpoint inhibitors. And I'll start probably with Mark, like, why immunotherapy in HCC? Of course, we're using it in many diseases, but why in HCC specific?
Well, I think that there's some definite interest in sort of before they start is the fact that with viral-mediated cancers, there seems to be increased antigen expression and sort of a propensity for the immune system to be activated. So from that perspective, trying to get the IO therapy into a viral-mediated cancer. What we found out in the clinical trials, though, is it doesn't have to be virally mediated to actually have a response or even a stable disease.
And HCC will go away by itself every now and then, like renal cell will do occasionally, suggesting that there is an immune attacking component from your body.
Yeah, sure.
Fair enough. So if anything, based on that, there was a concern, exactly as we just heard from Mark. Actually, there was an interest from the perspective of the inflammation / the viral infection, but also there was a concern. But nonetheless, ultimately, the efforts in HCC caught up with the efforts in regard to other diseases, and we went ahead and saw many trials that looked into the checkpoint inhibitors in HCC, and among which is the one that really was recently approved, which is nivolumab. Ruth, how was it approved?
Yeah, it's a quite interesting story. So most of the drugs in the previous time, you have to have a phase 3 trial to show survival benefit. And so this is based on a phase 1/2 study and the durable response. Amazing durable response by immune checkpoint inhibitor in HCC. So initially the study was a small phase 1 small cohort and generated a 20% response rate. And then there's an expansion cohort has been done, then include about 200 plus patients. And the response rate holds on like to be 15% in all 3 subgroups. 3 arms, patients with Hep B infected, Hep C infected, or non-viral. And then the duration of the response is quite amazing. So I think this data, when this data was presented to FDA, which led to the accelerated approval, of course, pending the phase 3 study that has been completed. Now we're following up on the data.
So this brings us back to the point that Amit started with, which is response at the end of the day is a very important focus that patients and physicians, of course, would like to really see a benefit in that regard. And the response rates that kind of average around 20% with the use of nivolumab in regard to second line in HCC went ahead and gave that conditional approval, which is pending the further evaluation of the drug in a study that's looking at nivolumab versus sorafenib in the first line setting. And so until then, however, nivolumab by all means is accessible and amenable to your patients per se.